The significance of distal embolization in patients with ST elevation myocardial infarction could be stated in three main claims. Distal embolization is a frequent flyer. Distal embolization is one of the main reasons for incomplete or failed myocardial reperfusion. Distal embolization results in poor clinical outcomes in patients with ST elevation MI treated by primary PCI. This statement justified use of dedicated devices for prevention and treatment of distal embolization. Aspiration thrombectomy was a most evidence-based and commonly used device for this purpose. The peak of routine use of aspiration thrombectomy was reached in 2012, when European guidelines recommended to consider routine use of aspiration thrombectomy, 2A class indication. Results of Infuse MI study was the first shock for the concept of routine use of aspiration thrombectomy. The main conclusion was aspiration thrombectomy did not reduce infarct size. The main conclusion of the test study was thromboaspiration did not improve mortality as opposite to the TAPAS study. The trial of routine thromboaspiration with PCI versus PCI alone in patients with ST elevation MI total trial showed that routine thrombectomy was associated with an increased rate of stroke within 1 month. Today, routine use of aspiration thrombectomy is not recommended, but in cases of large residual thrombus burden after opening the vessel with a guide wire or a balloon, thrombus aspiration may be considered. Various implantable devices were unsuccessfully attempted in patients with ST elevation myocardial infarction. Use of bioresorbable vascular scaffolds was considered in this group. The rationale is use of vascular reparative therapy in order to achieve benefits of engaged artery for long term, especially in young patients. On the one hand, absence of coronary calcification is an attractive feature in young patients, but aggressive pre- and post-dilatation with non-compliant balloon as an obligatory part of scaffold implantation suggests increased risk of distal embolization and side branch occlusion. The thick struts of bioresorbable scaffolds are associated with thrombogenicity and flow disturbance. Proved risk of scaffold thrombosis is a limiting factor in the use of this device in ST elevation MI patients. The stentus self-opposing stent attempt to solve the stent sizing dilemma. In a ST elevation MI patient, vasoconstriction and flow underfilling of infarct-related artery challenge the proper evaluation of the native vessel diameter. The aim of the stentus stent is to mimic the shape and diameter of the natural artery to achieve perfect apposition and adapt to anatomical changes during the post-MI phase to maintain apposition. MGuard is a stent that is wrapped with an ultra-thin polymer meshed net The idea was to block embolic shores and reduce distal embolization. The mechanism is thrombus to vessel shifting, compression, and gelling. Among patients with acute ST elevation myocardial infarction, the EMGARD resulted in superior rates of epicardial coronary flow and complete ST segment resolution, but a higher rate of one-ear target lesion failure stopped use of this device in ST elevation MI subset. The next dilemma is a culprit artery only versus multivessel revascularization during primary PCI. Multivessel coronary artery disease is present in half of patients presenting with ST elevation myocardial infarction and is associated with adverse prognosis. Initially, consensus was that intervention should not be performed in a non-infarct artery at the time of primary PCI in patients without hemodynamic compromise. Later was also claimed that PCI is indicated in a non-infarct artery at a time separate from primary PCI in patients who have spontaneous symptoms of myocardial ischemia or in patients with intermediate or higher risk finding on non-invasive testing. Further, it was concluded that intervention in a non-infarct artery at the time of primary PCI may be considered in stable patients. Finally, indication to routine revascularization of non-culprit lesions have been expanded and should be considered in patients with multivessel disease before hospital discharge. Invasive strategy in patients with ST elevation myocardial infarction and cardiogenic shock also underwent evolution. Initially, the concept was proved that early revascularization is preferred versus strategy of initial medical stabilization in this group of patients. Further, the expert consensus was that complete revascularization is preferred versus culprit lesion only in this subset. The most recently published culprit shock trial documented that among patients who had multivessel coronary artery disease and acute myocardial infarction with cardiogenic shock, the 1 month risk of composite of death or severe renal failure was low among those who initially underwent PCI of the culprit lesion only. Invasive strategy in patients with ST elevation myocardial infarction and culprit left main coronary artery lesion also underwent evolution from denial of the role of invasive strategy in this subset to next step was off-label use of PCI as bridge to surgery. Further, to off-label PCI instead to surgery in subset of excluded to surgery patients as a rule because to unacceptable surgical risk. And finally, PCI to culprit left main lesion is an alternative to surgery procedure based on evidence-based in the subsets of ST elevation MI, left main culprit lesion and TIMI flow less than 3, class 2A indication, and in patients rejected to surgery, PCI in left main is a class 2A indication. What is the future of invasive strategy? Firstly, is a differential approach and personalization of invasive strategy. Invasive strategy has to be selected according to type of coronary pathology, variant of anatomy, and clinical situation. Re-evaluation and development of unresolved concepts have to be done. By this, I mean myocardial preservation, regeneration, and so on. New evidence oriented to subsets of ST elevation myocardial infarction and new technologies providing dedicated primary PCI have to be implemented. We need to change our thinking that the ST elevation myocardial infarction is a universal clinical diagnosis. The mechanism of coronary occlusion can differ and depends on clinical situation. It may be ruptured plaque, coronary thromboembolism from mechanical valve, spontaneous coronary dissection, or in situ coronary artery thrombosis in patients with coagulopathy or thrombocytosis. The pathology of infarct-related artery obstruction can differ too. Infarct-related artery could be opened or closed. Thrombus burden could be present or not. Acute occlusion could be in the site of chronic lesion. In stent obstruction could be stent thrombosis or de novo lesion on basis of restenosis or late atherosclerosis. Culprits could be multi-site or hidden, or could be associated with coexistent cerebrovascular obstruction. The site of culprit lesion plays an important role and can be defined revascularization strategy as a left main location in the site of coronary bifurcation, aneurysmatic site, calcified lesion, status of artery before and after occlusion, status of non-infarct-related arteries, hidden infarct-related artery. Clinical condition could be differed too, from absolutely stable and mildly symptomatic situations to shock, CPR, life-threatening arrhythmias, mechanical complication. Patient bleeding and background play also an important role. These unresolved issues ultimately need future evaluation and development. Further optimization of management of patients with ST elevation myocardial infarction has to include new technology, implementation for prevention, early recognition, transportation, and urgent management of complication in pre-hospital stage. Optimization of post-hospital follow-up, rehabilitation, and evaluation. Invasive strategy will remain the main reperfusion approach and evolve to personalized, dedicated approach.